Thank you, Christina. Hello, dear colleagues. First, I have to apologize. I will not be able to speak in Hungarian. And I know, in addition, that your language is very sophisticated and very complex. And so I am obliged to speak in English. And in addition, thank you to give me the opportunity to discuss with you about this problem, the question of challenge and future of our profession, because this is a very important topic for the next decades. So, on my point of view, the main point at the moment is that there is a change in most societies. In most societies, people begin to understand that child and adolescent psychiatry is an important topic. And it was not the case in the previous year. And of course, the pandemic has been an important point here. The problem is that people in society, they understand that child and adolescent psychiatry is important, but they don't really know what is child and adolescent psychiatry. And another problem is that I am afraid that us, child and adolescent psychiatrists, child and adolescent psychologists, we are not always clear with what is child and adolescent psychiatry. And if we are not clear, then people will not be clear and people will not invest in our discipline. And so, the first challenge is, what is child and adolescent psychiatry? You will say, oh, this is obvious, this is what I teach, this is what I practice. Oh, be careful. And even with adult psychiatry, things are not so simple. What is psychiatry? Etymologically, it is to treat the disease of the soul. But what is the soul? And you know that at the moment in many countries, there is a tendency to engage in neuropsychiatry. And even some residents in my university, they told me, well, I am supposed to be a psychiatrist, but I have the feeling to become a neuriatrist, contraction of neurologist and psychiatrist. And so we have to be clear what is psychiatry today. This is my proposal, and we have to consider each word. Psychiatry is a discipline, a medical discipline, dedicated to the treatment of humans in rupture in their existence, and rupture is important, because of suffering that they feel as internal to themselves and not projected on the body that they inhabit. If you have a kidney stone, you suffer, there is a rupture in your existence, but you suffer in your body. If you have a depression or a panic attack, you suffer, but this suffering is internal to you. Of course, you will say, oh, this is less simple. You have some somatic disease with an internal suffering. Okay. But indeed, most of the time, when you have a leg that is broken, you suffer in the leg. When you are depressed, you suffer inside yourself. And in addition, you know that it has been shown by an anthropologist very recently that in all culture, all around the planet, human beings consider that there is something that is interiority and that is something that is physicality. And this is true in Amazonia, in Africa, in Asia, in Europe, in North America. Across culture, we will consider differently interiority and physicality. For instance, in Amazonia, interiority of human being is shared by the interiority of the river, of the plants. And in Europe, this is not the case. But anyway, there is interiority all across the planet, and so this is the reason why psychiatry is relevant when we consider the fact that we are treating people that suffer from their interiority. The problem is that in modern societies, the notion of interiority is a little bit old-fashioned. And what is curious, it is that it is even true for psychologists and psychiatrists. Many colleagues are afraid to say, well, this is a mental disorder, this is a disorder of interiority, because interiority is vague, you know. This is not material. And in our Occidental country, what is not material is nothing. And so mental disease are nothing. And this is, on my opinion, why, for instance, in psychiatry, we developed the concept of neurodevelopmental disorder. Why not? But neurodevelopmental disorder, if it is the case, why these diseases are not neurological disease? So this is the definition of psychiatry. Now, what is the definition of child and adolescent psychiatry? During many years, I consider that, well, child and adolescent psychiatry, this is the psychiatry of little persons. And in particular, because you know in France, child and adolescent psychiatrists are first trained as adult psychiatrists, which is not the case in all countries. And in fact, and this is very important to know that, to say that to politicians and to our adult psychiatrist colleagues, no, child and adolescent psychiatry, this is not a psychiatry of little person, this is more complex. Why? Because in my practice, most of my patients, I have an outpatient practice, when they come to see me with their parents, I ask them, what is your problem? Most of the time they say, I don't know. They bring me here, I don't know why I am here. And so you see the difference in that with child and adolescent psychiatry, it is a community that calls for help. And this community is for a problem with mind and behavior, okay, that is located in a youth. And this is the reason why in practice it is very different than adult psychiatry. And it is quite difficult to deal with that because, and you know that as me, when we are in an interview with a family, you have to deal with the whole family, which is quite different than with adult psychiatry. You have to consider the child, but also the parents, the sister, the brother, the school, the grandparents, etc., etc. It is systemic. So it is more complex from a clinical point of view, and it is more complex to explain it to politicians, you know. And in particular, just because it takes more time to do our consultation, because the problem is more complex, and so we need more money than adult psychiatry. And many politicians don't understand that. So indeed, child and adolescent psychiatry is a tricky thing. This is a discipline dedicated to the treatment of a community about the suffering of mind and behavior that is located in a youth. Now, second point, we have seen what is child and adolescent psychiatry, but who are our patients? Because we are treating patients. And to assess the amount of care that we have to determine in our country, we have to determine how many patients there are. And so, what is the definition of a patient? First point, we are all more or less biased about that. Because we have all a specific practice. You can have a private practice, a practice in a university hospital. You can have a general practice, or a practice that is specialized in autistic people, in patients with ADHD or eating disorder. And so we will not see the same type of patients. A very severe patient with autism is completely different with what we call in the past a mild Asperger patient that is in school and who is just a little bit different to other children or adolescents. And so when we discuss between each other about our patient, we have to take care that many times we are not speaking about the same people. Anyway, what does say epidemiology? The best study is the NCS Adolescent Supplement Study that was done at the beginning of the 2000 year in the US. Of course, in the US they are the best to do epidemiology in psychiatry. So the question is, what is the lifetime prevalence of mental disorder in adolescents aged 13 to 18? And these are the results. Depression about 9%, and I consider only the disorder with a significant clinical consequence. depression 9%, anxiety 8%, eating disorder 4%, etc., etc. What you see here is that as opposed to what many people believe, most child and adolescent psychiatric problems are quite acute, while for politicians, most child and adolescent psychiatric problems are quite chronic, which is not the case. Because you see, if you consider autism, intellectual disability that are chronic, only 3% of the population, and learning disorder, of course, they are more frequent, but this is something which is quite different. And so, most child and adolescent psychiatric problems are acute in nature. But this is not so simple. As I told you, first, on an epidemiological point of view, some of these disorders are quite acute, some are quite chronic, and it makes a difference when you will have to organize the healthcare system because it costs much more money to deal with chronic patients because it takes time. And the problem is that there is a continuity. You cannot say that depression is acute and autism is chronic. You know, some depression are chronic, and in fact, some autistic people have only some acute problem. There is also the question of severity. A patient with a mild form of ADHD is completely different than a patient with a very severe form of ADHD. Treatment will not be the same. And in my country, a child with a very severe form of ADHD will require that somebody will be close to him at school to help him to write and to take notes, etc. And so it will cost a lot of money. On a clinical point of view, this is not so simple also. In the previous slide, I mentioned depression, anxiety, ADHD, autism, but just time stop. I know we all speak about disorder with DSM diagnosis or ICD. But when you see a patient with autism or ADHD, do you really consider that you can summarize the problem of your patient only with the words ADHD or autism? No. I remember a patient with conduct disorder, all the criteria, but in fact he was hitting only his mother. So the problem in fact was deeper than conduct disorder. Is it a problem? In a way, no, because we have to propose treatment and these have to be evidence-based treatment, and evidence-based treatment are based on DSM diagnosis, and so we have to use DSM diagnosis, which is true. But our job is not only to propose treatments. Our job is also to make sense. And more I consider that this is the big part of our job. You know, we see families and they are lost. They have an adolescent with anorexia nervosa. Why? This is crazy. And the first part of our job is to explain what is anorexia nervosa, why it happens. And so we will have to use some concept of psychopathology, physiopathology, which are not inside the DSM. And so our patients are not only diagnoses, they are also a trajectory, a brain, interaction between family and themselves, and things that could happen while they were infant, trauma, etc. In the recent years, we have now something else, which are sociological considerations. And I will consider, for instance, autism. For 2 or 3 years, I have changed my mind about autism. Why? Because I had to deal with the autistic plan, with a plan on about autism proposed by our government, and I had to discuss with administrative staff and with patients that advocate for autism. There was a meeting and I had to organize discussion between all these guys. And autistic people that advocate for autism, they say, we are not patient. Autism is not a disease. This is not a disorder. This is not a disability. This is like being left-handed. When you are left-handed, you are different. We are autistic people. We are different. Because of this difference, we suffer. Because of this difference, we can need to see psychiatrists. We know we need psychiatrists and psychologists, but this is not because of autism. This is because society considers that we are different and make no place, no room for us. And so, in fact, I realize that in a way they are true. And so now I have changed my mind about who are our patients. And I don't know if in your country you have this problem, but in Australia, in Ireland, in North America, they have more and more adolescents with gender dysphoria. And in France at the moment, it begins to happen. Adolescents, they don't know if they are a girl, a boy, and sometimes in some country they decide to engage in to take medication to stop puberty and even to do surgery, which I think this is a major issue for the next decades in all countries. And so, is it a mental disorder? What is the place of psychiatrists in this situation? Are they patients or not? We have a particular place to take in this, and this is not so simple. This is not so simple because remember, we are not treating patients, we are treating a community that calls for help. And so the problem is more complex than in medicine in general and psychiatry in particular. A few words about research and teaching. Research and teaching is of course extremely important because research is the main way to improve our practice. And the good news is that research is international today. You can read papers in English, of course, so you can benefit from the works of people that are done everywhere, and in particular in North America, because perhaps you know that one child and adolescent psychiatrist on 2 on the planet works in the United States of America. So this is the reason why the way that North America consider about child and adolescent psychiatry is so important all around the planet. So international research is very important. We can share results, but local research is crucial. Why? Because you have to do research in your local area because there is an interaction between doing research and having a clinical practice. When you do always your clinic, there is a risk that you always do the same thing because it is so easy. Doing research is a way to change your mind, to open your mind. And in psychiatry, we need to open our mind. Research is, of course, also important when you teach, because you have to teach not your belief, but the facts that come from science. Even if you can also, when you teach, give your own opinion about the clinic. Experience of clinician is also important in teaching. Most important, in all countries, there are cultural specificities. And international research is not good to grasp cultural specificity. This is the reason we have to do local research also. This is specific to child and adolescent psychiatry. There is no unique theoretical background as opposed to cardiology, for instance, or even to neurology. Why? Because we have patients with a brain, for sure, and so we have to know neurobiology. But we have also a developing mind, and so we have to understand psychological development. We have also a family, and so we have to theorize relationship between people within a family. And we have a society, because children has to go to school. What is a school? And we have also religion. You know that to believe in God protect from addiction and suicide. And so, and of course, understanding the brain is not the good theory to understand why people believe in God. And so, child and adolescent psychiatrists, when they do research, they have to use many theoretical background. About teaching, because this is so complex, when we teach, we have to be humble. Many of us are experienced because, as me, I have a gray hair, and so I practice for many decades. But even if it is the case, you know, I make mistake every week, and I am afraid even big mistakes. I do wrong diagnosis, and I know that because patients come to see me 2 years after and say, in fact, it was not like that. Oh my God, I was wrong. That's life. That's life. We have to be humble. There is no truth in our profession. We have to deal and to work with the light profession. This is extremely important. And we are diverse. In particular with psychologists, in many countries, we have not the same words. This is not a good thing. We have to develop a common language. And this common language has to come from all sides. Psychologists, social workers, and psychiatrists. Psychiatrists have known the truth in here. There is a new concept, which is literacy. Literacy, it is the way that patient, family, administrative staff, politicians, they know, they have a culture about child and adolescent psychiatry. You know, just for instance, because of TV series like Sherlock Holmes, people know much better what is autism, what is Asperger's syndrome, you know, because in fact Sherlock has Asperger's syndrome. And so with a consultation, when you have a patient with Asperger, you can say, he is like Sherlock, and everybody know who is Sherlock. And this is a way to improve literacy. And for that, indeed, MAGYIPETT tried to develop a lot of resources. And you know that for high-level knowledge, there is now an e-textbook with many thousands of pages, which is the world reference in child and adolescent psychiatry, translated in many languages. And for literacy and for training of teacher, of social worker, there is a MOOC, massive open online course, which is free. The videos are on the MAGYIPETT website, where you can learn child and adolescent psychiatry, just the basics. Now, last challenge, how to structure the healthcare system. This is the most important challenge. Of course, it comes at last because it is the most important and because we have first to deal with the first, second and third challenge. How to structure the healthcare system? First, we have to understand that there are crazy equations. You know, the title of my presentation that you proposed to me was about mental health. And in many countries, psychiatrists are afraid to say psychiatry. They say mental health. And many people consider that mental health is just a soft word to say things about psychiatry. While in fact this is not true. If you look at the definition of mental health by WHO, mental health is well-being, coping, and working productively. Do you think that psychiatry, and child and adolescent psychiatry in particular, our job is to deal with well-being, coping, and working productively? Big risk to say that, because there is the risk to give methylphenidate to people just to improve marks at school. No. So why is there a problem? Because, of course, if mental health is well-being and working productively, in particular in school, we all want that youth are well. We all want youth have good marks. So we all want youth have a good mental health. But if mental health is equal to psychiatry in people's mind, then we all want that youth will have a contact with psychiatry. And this is crazy. There is of course no need that all youth need to see a child and adolescent psychiatrist. And so, and this is a real risk today, that there is a dilution of psychiatry within mental health. There is a second crazy thing, which is, on one side, we have to use evidence-based treatment, which is true. On the other side, evidence-based treatment, most of them are not sustainable. You know, our most important treatment in child adolescent psychiatry are psychotherapy. And evidence-based psychotherapy are very expensive. And this is completely impossible to propose such treatment to all children all around the planet. Even in France, this is completely unbelievable. Second, this is not feasible. Why? Because most, for instance, many evidence-based treatments are CBT. And in many countries, psychotherapists are of a psychoanalytic treatment, psychoanalytic training. And so it is not possible, it is not feasible to use this evidence-based treatment. And in addition, evidence-based treatment are not always culturally relevant. Imagine CBT in Africa. Are you sure that these are the best treatment for these kids? This is not sure. So, when considering the structure of the healthcare system, we have to consider a top-down approach, science and evidence-based, and a bottom-up approach. We have to consider that mental health is for politicians, because well-being is about politics. Child and adolescent psychiatry, this is a rupture about mind and behavior, and this is medicine, and this is the reason why this is psychiatry. Between psychiatry and mental health, there is a gray zone about chronicity, disability, deinstitutionalization, inclusion. Who has to work with that? It depends on the country in which you are living. It depends on history. Why? And also because there is a question of money. You know, this is my... I have only one or two slides, I promise. If you are in a country, in a rich country, if you are in a poor country, you will have more and less money, and so of course the structure of the healthcare system will have to be different. And you have to consider, as I said, the professional you have, and in some country, family can help, and e-health technology can help also, and this will be more and more true in the future. Okay, and so here is a proposition of how to structure a healthcare system, you know, vertical, hierarchical, and horizontal, from mental health prevention to the most specialized treatment, with evidence-based treatments that should be everywhere, but considering also that there are cultural specificity and that the budget is different. And you know, the budget is very important. Health insurance is for medicine, social budget is for prevention, and the gray zone. And so this is my conclusion. Society are changing, and this is an important opportunity for us today. We have first to be very clear with our profession. What is child and adolescent psychiatry? Who are our patients? Which research and training and teaching? We have to be clear, and we have to be clear when we will be clear with that, we will be able to design a rational healthcare system based on science, of course, but sustainable, feasible, and compatible with local history and culture. And I will be very glad to discuss that with you at the moment. Thank you.